morning, everybody. Today I'm introducing Dr. Michael Myburgh. Dr. Myburgh is an adult rheumatologist and specialist physician. After qualifying as a specialist physician in 2017, he completed his subspecialization in rheumatology at the University of Pretoria in 2022. He comes from an academic background, having worked as a consultant and lecturer at Kalafong Provincial Tertiary Hospital and Steve Biko Academic Hospital. Dr. Myburgh enjoys managing the full spectrum of rheumatological conditions with a special interest in inflammatory myopathies, a field which he has published. Outside of medicine, Dr. Myburgh is a family man who enjoys spending time in the outdoors. Thank you so much for coming to present to us today.
Morning. Thanks very much for the introduction. Thanks for the opportunity to talk today. Okay, so today I'm going to discuss something that I enjoy a lot, which is myositis, and it's a ever-expanding field that's developing a lot with not only on the side of investigations at the laboratory, but also clinically. We're learning a lot more about the disease as we go along. So what I'm going to be discussing today in depth is how we can make use of the immunoblot assay that we use for inflammatory myositis and see if we can't try and phenotype the patients a little bit better, and where we rely a lot on clinical examination to make the diagnosis, and then use the immunoblot more as a confirmatory test. I think that's the better way of going about it than just using it as a screen in the beginning, perhaps not for the right reasons, and then getting a surprising result coming back low positive or equivocal, and then you're not too sure what to do with it. Just so that you're aware, the myositis antibodies that we look at, now you've got different types. The myositis specific antibodies that you see listed up there, the Me2, MDA5, NXP2, TIP1 gamma, SRP, SAE, HMG co-reductase, and 4-limb domain is the specific antibodies. So these ones are quite good. If you're getting these positive, from positive to strong positive on your assay, then you should definitely take note of this test. We do like these specific antibodies, and we do find that we can at times clinically phenotype the patients quite well when we see these antibodies present. So we can, before we've requested the test, often predict which antibody is going to be positive here if we've done a thorough clinical examination. And they're also good because they give us a bit of an idea on prognosis as well as on malignancy associated risk. To come down to the associated antibodies, now these ones are a lot less specific, and they often occur in overlap syndrome. So we get these in a lot of other diseases: lupus, scleroderma, undifferentiated connective tissue disease, mixed connective tissue disease. So these ones we're a little bit not sure of. The CN1A is the one that we sometimes get with inclusion body myositis. All right, then also an interesting group are the expansion of the anti-synthetase antibodies. Now, these ones can be very interesting. In terms of clinical phenotyping, we tend to still look at the classic presentation, which I'll show you now, but I have seen patients who present with interesting rashes in this group as well. So this is also a nice group that we can expand on in the future, and maybe phenotype these patients a lot better as well. All right, so there you can see a typical example of immunoblot assay. We do have some assays now that give us more antibodies. And this is a very nice result that you see here, because we've got a strongly positive MDA5 and a strongly positive Rho52. And the Rho52 is often associated with myositis, and you'll often see it positive along with another antibody in the immunoblot. All right, this is not projecting too well. I'm not too sure why. It was fine before, but all right, what this is basically showing is your prevalence and your specificity of the immunoblot. So what I just want to show you is the The best antibody still in terms of myositis is the JO1. So you'll see on the classification criteria for myositis, JO1 is the only antibody that they will still include as significant. It doesn't mean that the others are not significant. It just means that we know if we see a JO1, we should take it very seriously and we should look very nicely for features suggestive of antisynthetase syndrome. You'll see now they mention the specificity of these antibodies as being extremely high. But again, this is going to depend on what result is coming back. So if you've got a patient who's got a high positive result and obviously clinical features and a pretest probability that was high, then definitely that will help you. If it's come back with multiple antibodies, but perhaps on one test that are low positive or equivocal, that doesn't mean too much. So who needs a myositis profile? Right, so obviously a patient who's got proximal muscle weakness. This is the most common presentation that we will see. But don't forget patients who present with dysphagia. Dysphagia is a very common complication of myositis, and a lot of the patients often don't mention it to you, so do ask them about that. Obviously, a patient with an elevated CK, sometimes they aren't weak, so you might find a clinically amyopathic patient. Don't forget that usually the patient's CK is not massively elevated like we see in the rhabdomyolysis patients, and it's not usually a very acute presentation. Sometimes it can be. Sometimes we see a patient, they present very acutely, the CKs are extremely high, they've got myalgia associated as well, and in that group we'll be more worried about a necrotizing myopathy. Right. Obviously, rash associated with dermatomyositis or other autoimmune diseases. Then in patients who you've picked up polyarthritis, Raynaud's, and maybe you thought that this patient was going to have lupus, but now you found a negative ANA. This is important because a lot of those antibodies we're looking at are found in the cytoplasm. So often the ANA comes back negative. So if you're dealing with a patient, you're unsure what's going on, you thought it was a lupus, there was rash, there was joints involved, then and you get a negative ANA, remember about the myositis profile in the C case. Same for someone with arthritis and a negative rheumatoid factor in CCP. And then just remember that we don't miss it. Patients with psoriasis, they might present with what looks like an autoimmune disease. They can come in sometimes with Raynaud's, they can get splinter hemorrhages, positive capillaroscopy, and obviously the arthritis with rash. So just make sure you have a look and just check that it's not more in keeping with the psoriasis rash that this patient is dealing with. All right, then the ILD group, that's where it becomes a bit tricky because you pick up the ILD and not necessarily too much clinical features of autoimmunity, and sometimes the rashes can be quite subtle, they can be hiding away. If you don't go look nicely for the mechanic hands, you might miss them quite easily. So the ILD group becomes a group where we tend to do a lot of the myositis profile, and then we look for the clinical features afterwards. Okay, don't forget about cutaneous ulcerations. So I'll show you a few patients just now where the patient presents not really with rash, but they present with ulcers, typically on extensor surfaces and on knuckles and things like that. And you don't want to miss a very aggressive myositis in this group, which I'll show you just now. All right, then also cancer-associated weakness. If your patient who's got a history of cancer in the recent past now all of a sudden complains, of proximal muscle weakness, remember there's a lot of association with cancer and dermatomyositis. All right, and then don't forget about this group, the elderly patients who present to you with more an asymmetrical picture and more distal weakness and neuropathy. This could fit in with an inclusion body myositis, which is fairly rare to see, but we do come across it now and then. All right, so this diagram just demonstrates to you nicely what to look out for and which of these. What I like about this diagram is that it does show you what's most commonly encountered in these patients. Okay, so as you can see, the weakness typically proximal and symmetric, and it's usually not painful. Right, you guys know to look for proximal around the hip, shoulder abductors, and don't forget about the neck. So if the patient can't flex the neck, then that's quite a worrying sign for us. We usually then want to treat the patient very aggressively because the next thing that's going to be involved is potentially respiratory muscles. The typical rashes that they mention here are the ones that we encounter most of the time, but they don't encompass all the rashes that we deal with. Okay, so remember Gottron's papules. These are the elevated plaques. They can be different in color. They can be anything from erythematous to depigmented to brown, purple, and they occur usually on the knuckles of the hands and feet. However, Gottron's sign is when it's occurring on the extensor surfaces on the knee and the elbow. The heliotrope rash is that erythematous rash occurring around the eye and around the nose and also up towards the forehead. And it sometimes then also causes associated periorbital edema. Right, so ask your patient about that. That comes and goes, and you need to ask about that on the history. V sign is quite typically seen on the V of the neck. However, in rheumatology, we do get a lot of rashes that appear on the V of the neck. So just be a little bit careful. Even something as simple as mast cell activation, they get this flushing around the neck. Shawl sign, which is like a cape going down the back, from the neck down along the back. And then the holster sign, which is along the side of the leg in the position of a holster of a gun. All right, but we do have other ones. We've got the sleeve sign, which runs down the arm as well. And often we get, as I mentioned before, the ulcerations which occur on the extensor surfaces. All right, then don't forget when you examine the hands, look nicely for cuticle overgrowth. All right, and they usually have these ragged edges. And then also look for calcinosis. And you might also pick this up on x-rays. This can usually be a little bit tender for the patient, so they might complain of a little bit of myalgia as well. All right, then the inflammatory arthritis, very typically in the antisynthetase group. Don't forget about cardiac involvement. I'll show you the antibody that we associate mostly with cardiac involvement. Raynaud's is a big feature because remember, this is actually a vascular disease. It's got a lot of vascular component to it and endothelial activation. Interstitial lung disease we've mentioned, and I'll show you a patient who developed a spontaneous pneumomediastinum, which is quite a serious complication of one of our subsets of diseases. And then there's the dysphagia again, not to forget. Okay, if we look at the diagnostic criteria over the years, you'll see way back in 1975 was the first one that came out, Bone and Peter, and it was fairly good, and there they relied on biopsy as well. And then in 2017, they changed the criteria and more evidence-based criteria, and you can see it performs very well. In the new criteria, they look at two groups. So one where the patient has had a biopsy, and then when your patient hasn't had a biopsy. So you'll see specificity, very good, accuracy, very good, even without the biopsy. Okay, so if you've got enough clinical signs with rash and CKs and proximal weakness, you don't have to proceed to a biopsy. We usually will do biopsies in patients who present atypically and we're not sure exactly what we're dealing with. If we're worried perhaps about a necrotizing myopathy, we could then proceed to biopsy. A lot of the previous patients that were labeled as a polymyositis, for instance, they are very often being reclassified now into other groups, a lot of them into the necrotizing group, the signal recognition particle patients, and the HMG co-reductase ones. All right, so as you can see, what we're trying to do as time goes on is adding more rashes to the picture and then adding more myositis-specific antibodies. And eventually, where we're going to end up, if you look at the progression, is this comes from an article that you can go and have a look at, where they looked at whether they can use machine learning to diagnose the patients using genomics, which looks at the DNA, proteomics, looking at all sorts of different proteins, mRNA, and expansion on the myositis antibodies. All right, so what are these antibodies that we're testing? So I'm not going to go through all of them, but I think it's nice to have a little bit of an idea of what these things are, because it helps you also to understand potentially some of the manifestations and triggers of the disease. Okay, so MDA5, this is a RIG1-like receptor that recognizes double-stranded RNA of many viruses activating interferon pathway. Okay, so a lot of the myositises, they are what we call interferonopathy. So interferon plays a big role in the inflammation here. And with MDA5 and the virus link, there's a strong link to many viruses, including when COVID came out. And I must say, I don't know if we were just not looking for it, but I have seen a lot more MDA5 patients post-COVID. Okay, NXP2, this is a protein that participates in the P53-induced cellular senescence when oncogenic signals are present. Hence, the NXP2 is associated with cancer. TIF1 gamma, this is a protein that functions in many cellular processes, including DNA repair, cell signaling, apoptosis and transcription, and cell differentiation. So you can imagine that also has a link towards cancer because of the process that it's involved in. Me2, which is the old most common one that we're used to seeing with dermatomyositis, is a nucleosome helicase that forms part of the NERD complex with a specific function in skin development. So you can imagine when you see these patients that often have significant skin disease. Okay, so I'm going to run through some of the clinical signs and manifestations that we get. And I think this is quite important so that you can better clinically assess the patient before you look just at the investigations. And this comes out of a very nice article from Nature on myositis, and I can give you the details for that later. It's a very nice review, a primer on inflammatory myositis. Okay, so here's the one that we're most accustomed to from when we were doing our training. This is the anti-Me2 dermatomyositis. All right, so predominant features here are the rash. The patient often has the heliotrope rash, the shawl sign, as you can see there, V sign on the neck. They usually have very significant myositis. So these patients can present with extreme weakness. I've had quite a few of these patients who were bedbound, couldn't swallow, they needed nasogastric feeding, and so they can have quite significant weakness. They typically have all the nice signs, the Gottrins, the cuticle overgrowth is one of the most common features in this group. And luckily in this group, the response to therapy is usually favorable. So even though they present with severe manifestations, they do respond very nice to therapy usually. Okay, TIF1 gamma. This is an interesting group of patients. I just want to point out, so they usually do come in with significant rash, all right? But what's more a feature on them is this poikiloderma. So you might start seeing what you think is something that looks like a salt and pepper rash that you know from scleroderma. And this presents with, for instance, a lot more hypopigmentation. When you get the Gottrins papules, they're usually hypopigmented. So a bit of a different presentation here. They might have some edema, which we've seen on patients. And the big thing with this group is the risk of malignancy. So in this group, the risk of malignancy is the highest out of all of the myositis antibodies that we're dealing with. Okay, NXP2, these patients present also usually with rash. They also have a risk of malignancy. This is the second highest risk in this group. I must say, of late, I've seen 2 patients with NXP2 who've had breast cancer. So just be careful of this one. Definitely screen for cancer here. It's quite important. But the other feature of this disease, and I saw it in a patient recently very nicely as well, and is the calcinosis. All right, so I'll show you that now. Calcinosis in myositis is usually a bit different to what you see in scleroderma. It usually occurs within the muscle, so we call it a sheet-like calcification. And it usually does induce a little bit of pain as well, but it can make the muscles extremely hard as well from the calcification. The lady I recently saw with the breast cancer mentioned that even before she developed the breast cancer, she went for a surgery on her hip. And the orthopod said to her afterwards that he encountered some, what he thought was caseous material when he cut open her muscle, which was in fact just the calcinosis. Okay, MDA5. This is a very aggressive form that you don't want to miss. There are a few different phenotypes of this disease. There seems to be 2 different types. There's one that is less severe than the other. But I would encourage you to just look out for the severe signs and treat aggressively in this group. All right, so they can present with rash, but often they might just present with these ulcerations. Okay, they're typically on the hands, as well as a sign called inverse Gottron's papules, which I'll show you shortly. They can be completely amyopathic, this group. So you might find no weakness, you might find no elevation of the CK or only a mild elevation of the CK. And then here, the risk of interstitial lung disease is the big problem. And I have seen patients before with rapidly progressive disease, and it's not nice because it's difficult to treat. And this is what you need to look out for in this group of patients. You don't want to miss this. And we'll get to the therapy of that later. Okay, SAE is a small ubiquitin-like modifier activating enzyme. Also plays a role in cell signaling and things like that. This one also has a smaller risk for cancer, but still present. I only recently saw my first patient with this, which was a patient who had Asian descent. These patients present with interstitial lung disease, typical rash, and periungual telangiectasia is quite a prominent feature of them. And I remember the patient I recently had did have quite significant periungual telangiectasia. All right, antisynthetase syndrome. So this is the group that we could still possibly phenotype a little bit better. If you look here, what they mention is all the usual things that we're used to finding in this group. So it's fever. The rash is very inconsistent. So sometimes they don't present with any rash at all. They develop the interstitial lung disease. Myositis, definitely the CKs are usually elevated here. And then the thing to look out for is the arthritis and the mechanic hands and the Raynaud's phenomenon. So I have seen patients with arthritis without mechanic hands, without Raynaud's, so you don't have to get it in combination. But specifically go and look for the mechanic hands. That one is easily overlooked if you don't look nicely for it. All right, the IMNN is what we call the immune-mediated necrotizing myopathy. This group is quite aggressive. This group responds quite slowly, but eventually does respond to therapy. The patients in this group can be very debilitated. They present with quite an aggressive form of necrotizing myopathy. So for these patients, I think biopsy is quite worthwhile because it's nice to see the necrotizing features on the biopsy. Then at least you know your therapy should be quite aggressive. And don't forget that in this group, they present with cardiac involvement. So just go and screen them for that as well. The two antibodies that we see in this group are the SRP, signal recognition particle, and then the HMG co-reductase, which isn't easily, we can't test for it on a lot of the panels, which is an interesting thing. Right. This is the inclusion body myositis. So this group is usually a bit more elderly. They present to you quite atypically. They've got less prominent weakness. However, it's often missed because you don't think of it because it's more distal in nature, and the patient presents as well with some neuropathy at times. So you tend to think it's more of a neuropathy going on. But they have more of this distal involvement, and then over time they can end up, if they get enough atrophy, with the scoop sign on the forearm, scooping out of the muscle there. All right, this one is difficult to treat. I haven't seen many of them, but if you read the literature, it's typically a difficult disease to treat. Yeah, so just be aware of that one. Not going to go into too much detail on what we see on muscle biopsy, but I think what's important to look at here is, okay, why would I do it? I'd maybe want to go and look for inclusion body myositis. So go look for the inclusion bodies on the biopsy and the necrotizing type. What I think you must also just have a look for here is the predominance of T cells. So you'll see a lot of T cell infiltration perimysial and within the muscle. And that's quite important because I don't want you to forget about when you're treating these patients to look at drugs that are affecting your T cells. That's why I still think quite a big place for the calcineurin inhibitors in treating this disease, especially if you're not winning on your initial therapy. The calcineurin inhibitors inhibit T cell activation, and they can be very helpful in this group of patients. Okay, so we can do a bit of a quiz now if you want. So if you look at this, you guys know what we're depicting here. This is calcinosis again. You can see it's in the muscle, so it follows the muscle. All right, anyone want to have a guess at which antibody will be positive in this group?
Anti-cure.
Mm-hmm. Seems like you weren't paying attention. Okay, so this is going to be your NXP2. All right, so strongly positive. So when you see calcinosis like that, it often occurs in the juvenile group as well. So definitely go and look. Most of the patients where I see a severe calcinosis are NXP2 positive. All right, and then your next step would be, if it's not a pediatric patient, if it's an adult, you'd want to go look for a malignancy potentially. Yeah. All right, what are we depicting here? Cuticle overgrowth. You can see the ragged edges, right? And then you can even see with the naked eye, this patient's got microhemorrhages and dilated capillaries, right? What's interesting on this picture is the nails as well. So this patient has some ridging, but I must say that this type of ridging of the nail I see in many different patients, including myself. And so I'm not too sure this is specific to psoriasis. But okay, so which antibodies do you think this will be positive in? So in me2, hey? Right. So me2 often get the cuticle overgrowth with the capillary changes. All right, so here you can see this patient presents with ulcerations on the knuckles. You can see the tapering off of the fingers due to some arthritis. And then if you look here on the palm of the hand, what you're seeing here is what we call inverse Gottron's papules. Right? So sometimes inverse Gottron's papules are also palpable. So you might actually pick it up just by feeling in that area. Okay, so this is a feature of which antibody?
I'll call the rheumatologist.
Yeah, so this is a feature of MDA5. Okay, so this one you can diagnose clinically for sure. Eh? If you see that, clinical diagnosis, and don't miss it because this is one you want to treat very aggressive. Interestingly enough, that patient on scope had a watermelon stomach. So yeah, this was a very interesting presentation of GAVE in a patient with MDA5 dermatomyositis, patient that I had at Kalafong. All right, so this was another patient I saw. This patient was quite interesting because he presented with more pain, proximal muscle pain, not so much weakness, and then his hands looked like this. I mean, what you're seeing here almost looks like what you see in porphyria sometimes. Anyways, he responded very well to therapy on the skin, but on his muscles, he didn't respond very well. And this one, I didn't know what it was going to be. And what came back positive here was one of the myositis-associated antibodies, the anti-Ku. All right, so anti-Ku is a difficult one. There is a very nice article where they try and phenotype these patients, but when you read it, you'll realize it's extremely heterogeneous and they're not very well understood. I must say, some of the patients that I've seen with this antibody seem to present almost like a polymyalgia rheumatica picture. But we'll have to see what develops in time with this antibody. And remember, it's more an associated one. It's not very specific. All right, so this was a nice one. Depigmented patch. You won't know what this is. I also didn't know what this is, and I got the name for this out of a dermatology textbook. I was actually just lucky that when we saw this patient, a dermatology fellow was rotating with me, and she had a dermatology book there. So we opened the book and had a look. So you'll see it's depigmented. So that's the first clue. And you'll see some depigmentation next to this lesion. And then what this lesion is called a red on white patch. Okay, a red on white patch. And it's actually interesting because it's a pathognomonic sign in this group. So this is a patient with TIP1 gamma. Okay, TIP1 gamma positive. And this group is now also the group where we really get worried about a malignant process. So we went ahead and we screened this patient for malignancy. And yeah, they found what they thought could be gallbladder carcinoma on scan. And we obviously went and removed it. And well, it came back as a lipoma, gallbladder lipoma. So yeah, no cancer, lucky for her. However, what you will do now is, especially in the next 3 years, you'll have to monitor this patient quite closely. Okay, this is the back of a patient's leg, and this was a very interesting one because I've never seen it before, and I've never seen it again. It was extremely symmetrical, and it was running down in a V shape on the back of the patient's leg on both sides. And also, I wasn't sure what we were going to be dealing with here. And yeah, I don't know. This is what it came back as. So, Me2 positive, PL12 positive, strongly, PL7 positive, Rho52 positive. And I can tell you that this patient did have interstitial lung disease, and she obviously had quite a bit of skin involvement. So, which is the culprit here? I'm not too sure, because Me usually spares the lung. So was this all PL12? So you can see where the problem comes in here. At least the antibodies were strongly positive. So, and clinical picture did fit in. So luckily, we were quite convinced that, okay, these antibodies that we saw multiple of, some of them were significant. All right, so this is actually the very first patient that got me interested in myositis. Just because when I saw this patient, he was 15 years old, and I saw him at the rheumatology clinic at Kalafong. I actually didn't know what I was looking at here. He came in with a history that all of a sudden he was a very good soccer player. All of a sudden he couldn't play soccer anymore. He was too fatigued and too weak. He developed some arthritis of his fingers and of his knees, and I remember he had some swelling around the knee. And all he had at presentation were these 2 lesions over there, and there's another one over there. And as you can see, quite symmetrical. And I really didn't know what this was. And, everyone was talking about lupus, and I just wasn't happy that, well, not everything is lupus. And I literally asked Google, what this could be, and that's how I diagnosed this patient. And since then, I had a long journey with this patient. This is what eventually developed on this patient: severe ulceration. This is on his elbows. The ulcerations occurred on the hips, occurred on the knees, occurred on the shoulders. His hands ended up with flexion deformities, and we treated this patient very aggressively. He also developed septic arthritis because of the open lesions he had here on the joint. And after about 2 years, he developed, it was about a year and a half, he developed acute chest pain. Right, and you can see this is a spontaneous pneumomediastinum, right? And luckily, this patient responded just to conservative therapy, and this resolved. But this is a well-known complication of MDA5 dermatomyositis, mechanism being most likely involved with the bronchial arteries, and a vasculopathy that occurs in the bronchial arteries. And luckily, this patient survived this encounter. And this is in 2 years later. So what I've noticed with a lot of the myositis diseases is initially they can be quite aggressive, but unlike lupus, there's an acute phase and then it tends to improve with time. So if you can get your patient through that first few years, then they end up doing well. So he was a lot thinner than this. He developed a little bit of Cushing features. He actually did develop compression fracture of his spine. These are how the lesions eventually responded. He was on an aggressive regimen, this patient. He went through basically all the drugs. He ended up on a combination of rituximab and cyclosporin and steroids. And at least now he's doing very well. So, he was my first MDA5 patient and quite a challenge. But this is what we want to prevent. This is what you see, a lot of atrophy around the proximal deltoid area. Right. So this is what I want you to remember just in terms of these antibodies. And these are some interesting associations that we saw. TIF1 out of Kaposi sarcoma patient, the TIF1 of the gallbladder lipoma, the NXP2 with chronic hepatitis B, and you had to exclude HCC on him. The MDA5 I showed you with the GAIB, spontaneous pneumomediastinum. Remember the big three for cancer there. Right, this doesn't project too nicely for you, but what this is just a flow diagram to help you to decide, okay, how aggressive do I need to be in my workup of malignancy when I do come across a patient like this? So I think what's important here, okay, which ones must we work up? Which ones do we not worry too much? Okay, so luckily in the anti-synthetase group, we don't have a strong association at all. That's low risk. CTD-associated myositis, so remember scleroderma, lupus, they can also get myositis. Okay, so your signal recognition particle, necrotizing group, anti-Jo, other anti-synthetase antibodies, and the myositis associated and not specific antibodies. Those patients have a less chance of developing malignancy. So we're not too concerned of looking in that group. The group that we are worried about when they present with a lot of skin manifestations and they have the TIF1 gamma or the NXP2. You'll see the SAE is luckily here in the intermediate group. Age older than 40, high disease activity despite your therapy, so they don't respond too well to therapy. That should be a red flag for you. They mentioned dysphagia. Okay, that's quite interesting. And then cutaneous necrosis, which are ulcerations as well. Right, then you go and you do a screen, which is usually age appropriate. Most of the time, I would say breast, abdomen, pap smear. Those are your biggest ones to go and have a look for. Sometimes in the Asian population, they were dealing with a bit of nasopharyngeal carcinoma as well. Right, but this is just so that you're aware. Don't forget about looking for this. And it's important that the patient can present initially with the dermatomyositis only later. get the malignancy. So I think that's what I've seen mostly. So just have a high index of suspicion within the first 3 years. All right, so just an outline that can guide you a little bit on management. Okay, so we do obviously like corticosteroids in the initial phase of the therapy, and we do like relatively high doses, and we do prefer a slower taper in the myositis group than we do in other diseases. And we know it works quickly, so we want to get the inflammation under control, so we'll end up pulsing the patient. You'll see our first-line therapy is still methotrexate as a theoprime. Both are great. I've noticed the neurologists, if they're dealing with the disease, they prefer to use as a theoprime. Rheumatologists, we much prefer methotrexate. Then second line, and sometimes you'll bring it in the beginning as well, is your cyclosporin or tacrolimus again to inhibit the T-cell activation. I am very fond of this drug in a lot of diseases, including this one. MMF is okay. Third line is where you start looking at rituximab. Sometimes your patient might be sick enough that you want to use this as a first-line agent as well. And definitely if you're worried about an aggressive ILD that's present as well. If you can't get access to it, then cyclophosphamide. And then at any stage, you can consider using IVIG or some modulation therapy there. What's good about that is it at least buys you some time. It gives you about a month of time to play around with your other drugs. So because this usually modulates you and will hang around in your system for about a month. All right, so don't forget about that. In terms of biologics, the only drug that's really coming through that seems to be of use is the JAK inhibitor, tocilizumab, and we can use that in the MDA5 group. These are for if your patient becomes refractory. I'm not going to go into too much detail here, but like I've mentioned there before, in the third line therapy, you tend to just probably go and give them some initial IVIG, and then consider rituximab or cyclophosphamide. I think that's the easiest route to take if your first-line therapy hasn't worked. Or the addition of the calcineurin inhibitor, which is probably what I would do. This, I think, is an important one just to finish off on, and this is the one that I don't think we should miss, so the rapidly progressive ILD. So these patients come in and they will have a deterioration of lung function within a few months. And this is where you need to go and look for the features of MDA5. Because if you pick up the features and the patient has presented to you already with interstitial lung disease, then you don't really have any time to wait. I have had patients that demised within months of diagnosis with this, despite aggressive therapy. So we must be aggressive here. What I would recommend and what they also recommend here is a pulse of steroids, and from the outset, you give 2 therapies. So usually rituximab, and you can give rituximab plus cyclophosphamide. It's called potent B-cell depletion therapy. You can give that, or you can give rituximab plus a calcineurin inhibitor, which is what I would like to give. And then the addition of the IVIG as well will also help. So do look out for this group of diseases. This is a very fatal complication, and the mortality rate here is higher than 50% at this stage. So do treat this extremely aggressively. And that's the end of the talk. Thanks.
Thank you, Michael. This is a really nice presentation.
Any questions?
Welcome to join us again.
I just have a question. What is your experience with cyclone interstitial lung disease?
Cyclophosphamide.
Yeah, because I know you've used it here for ILD, but I mean, theoretically, cyclophosphamide can cause interstitial lung disease as one of the rare complications.
Yeah, I don't think we don't usually see it too much. Perhaps if you're taking long-term oral cyclophosphamide, but no, I think what you might find there is often it's just the disease and not the therapy that's causing the damage. It's like, when we were worried about methotrexate in the lung before, there again, it was more just the disease that and the inflammation that's causing the injury to the lung and not the disease, not the medication. Now we know that, methotrexate is actually protective for the lung in that group as well. So, no, I don't think it's a big issue at all.
Just a matter for men with interstitial lung disease, of course, the myositis with the interstitial lung disease. So maybe perhaps it's very important to understand what kind of interstitial lung disease they cause, because interstitial lung disease is just a group of disease that can be fibrotic and can be also acute, subacute, obviously. And the indication, of course, I think we have no experience of cyclophosphamide causing actually drug-induced interstitial lung disease. But just to mention that we never really use endoxin on those patients who have fibrotic lung disease. They are more indicated in patients with the NSIP pattern. That's where it's indicated and obviously as a beginning of the therapy together with the steroid. And most of the time, the outcome is extremely very good. And that's what the anti-synthesis syndromes are really known to cause more reversible interstitial lung disease, means mostly cellular kind of NSIP. And I think normally we combine the steroid at the beginning, and obviously we use the Euro cycle regime where they give them 6 cycles over 6 weeks. And normally they do extremely very well. Sometimes the lung clear out completely. And yeah, so we've never really seen that. As the same as Michael also alluded to the fact that I think methotrexate again, we have not seen that at all. So the most culprit that we have seen, of course, is microdentin. We have seen more of biological that are used to treat melanomas and also for anti-cancer treatments and all of the above. That's what is known really, but unlikely to be rheumatoid. I think in the past they could have talked about gall, about all those things that could have been caused. So in terms of interstitial lung disease, I think cyclophosphamide is extremely very safe, but also there have to be clear indications. So it's about who should be getting cyclophosphamide. I think obviously we look at the females. If then fertility, age, we tend to avoid it. The reason is because you never know, and you don't want to be under medical legal, where sometimes you find that suddenly someone want to have a baby, and other people you already they because of cyclophosphamide interaction with ovary itself, then become a problem. Yeah. So I think on our side, the answer is no. Endoxin is actually safe. In terms of the oral endoxin, that we never really use because the risk of the bladder CA actually increases. So we actually stay out of that on the oral one. So IV 6 cycle, extremely very safe with no problem.
I think what's good in this group as well, the rapidly progressive group, is you want something that works very quickly. That drug causes immediate alkylation, and so you have an immediate effect. So, and I mean, it should be easy for you to convince your patient in this group to use it because of the mortality risk. So definitely I would use it. And I think in private as well, when you're battling to get these things motivating, you don't have time, then at least you've got this freely available and it's fairly cheap. So go for it.
But I think medical aid anyway, they require for cellular NSIP, they wanted steroid first, then they want endoxin first, after endoxin, then they go to CellCept, then rituximab. But what I want to come back to, Michael, I think, listen, this is a great presentation. Well done. I think the pictures are amazing, and I just hope that one day you can publish a small kind of a handbook of the myositis, because really it looked beautiful. But I mean, I'm a pulmonologist. I have so much in my head. You obviously don't have time to have a look. Imagine if you have a handbook that you can actually view and attach them really to the antibodies. So what I want to ask you really regarding the role of those antibodies, we now normally do a lot of them. And I think Ampart Labs has been one of the leading in terms of the serology for the auto antibodies. And sometimes you get some of the tests has been low positive, higher, or equivocal. Now the question, where do you draw the lines?
Yeah. So for me, definitely equivocal. I don't consider it all positive. I like to see a positive at least.
As long as low, you don't have issues.
Low positive. The problem with low positive, I have definitely seen patients with low positive with disease. So I can't rule that one out. But if you haven't done it for the right reason and you get a low positive result, it's not going to be very significant. If you've got a patient in front of you that clinically has got the right features and the test comes back low positive, that's fine. The patient I had recently, who I saw sent to me NXP2 low positive. But when I saw the patient, clear cut, calcinosis. I think the reason maybe for the low positivity, she'd been walking around for more than 5 years with disease. So that's another.
And then my last final question about the myth in autoimmune antibodies and COVID-19 vaccines. What's your opinion? Because everyone said that it's all COVID vaccines or COVID per se. What's your experience and your opinion? Do you have any?
Yes, so there's a lot of data on COVID itself. The vaccine is still exposure to a virus, so it can trigger your immune system. And, you know, if you've got the wrong genetic makeup and your immune system gets triggered and you're unlucky enough to develop an autoimmune disease because this virus has triggered your immune system down this road, then that's what happens. And that's why with the MDA5, you'll see it's associated with viruses, and that's where its role is. So there's a strong association with MDA5 and autoimmune disease. Same as, you know, cancers and autoimmune disease with Epstein-Barr virus. There's a very strong correlation there. And we know we all get exposed to Epstein-Barr, but we don't all develop lymphoma or autoimmune diseases. So it just depends on your own genetic makeup.
I think I absolutely agree with you. And I always say that the COVID-19 actually unmasks what's already exists in your genetics channels, because it's not really attributed to anybody else. But I think probably there's no clear evidence to say that actually COVID-19 vaccine can induce interstitial lung disease or trigger the antibodies to attack the lungs. I think probably it's that remain a myth on that aspect. Anybody else with good questions? Karaba, you're nodding your head.
Yeah, I think, look,
Yeah.
you know, we like being sitting in a grey area. We're quite comfortable there. So it's not black and white.
Darren, you're online before. Do you want to say something?
Hi, guys. Thanks for the talk. Yeah, Michael and I chat about these diseases often because either they present to him and then he finds the lung disease, or I find the lung disease and then suddenly find an antibody. And it becomes incredibly hard to know really what to do with these antibodies when you find them. So what we tend to do, we see the patient with an interstitial process. It's usually, Emmanuel, you'll back me up, it's often doesn't follow a clear pattern. It's kind of a very atypical interstitial process. So you do these antibodies as part of the workup for this undifferentiated interstitial lung disease, and then they come back positive. So they often fall into this IPAF group, which is a very ill-defined group of interstitial lung diseases. And what makes life very difficult, especially now that I'm treating these patients in private, is that the medical aids don't recognize this as an entity. So to get appropriate therapy, especially for the more aggressive interstitial lung disease patients, is quite difficult. I've got a lady right now who the medical aids have declined rituximab on appeal. And she's got these antibodies positive with a progressive fibrotic interstitial lung disease. So I think a lot more work needs to be done here generally, you know, worldwide. And Emmanuel, I don't know if you've seen, but they've actually now recently reclassified interstitial lung disease. It's in press at the moment. And still IPAF is not part of that classification, and the myositis group of interstitial lung diseases are still not part of that classification. So, you know, it tells you where we are with research in this at the moment around the world. A long way to go still.
Yeah, I think I always say that we actually in South Africa, we possess a huge amount of data. Unfortunately, most of those data are just like probably most of our our previous generation that they've never been published. And I think actually we need to be able really to put those things into publications based on experience in South Africa, and actually probably be leaders in it. So I think I agree with you, Darren. And the problem that, again, we don't know sometimes egg or chicken. That's why we call them IPAF. We don't know which one starts first. And actually, what does it mean? That's why it's always very nice to have rheumatologists that really got interest in antisensitive syndrome. So, Michael, just last questions. The questions that always have been these autoantibodies. You did mention clearly about the role of malignancy, that there could be paraneoplastic manifestation. And we have seen quite a few of them with Dr. Van Rooyen, who've been in MIDSTREAM quite for a while. So in your case, in your opinion, you could answer or not, you could choose not to answer. When do you actually start malignant investigations? The question that with the role of lung biopsy for me, as long if it's clear, straightforward, no lung biopsy, you do treatment if the symptoms are in keeping. But however, if the autoantibodies are very negative and you're worried about the sovereign, that's why sometimes we do biopsy and all those. But in your case, patient Alexander syndrome with clinical evidence and everything, which age actually do you use to as a cutoff to do a malignant workup, or do you do routine on everybody?
No, I don't routine on everyone. I think, as that table shows, the anti-synthetase group is low risk for malignancy. So I don't think you need to be too concerned there. As I mentioned, those antibodies where we do get concerned, definitely the TIF1 gamma and the NXP2, less so the smaller ubiquitin-like modifier. And then depending on what age the patient presents, and they usually present with a lot of skin signs. So if it's an elderly lady presenting all of a sudden with a rash and proximal weakness, I would screen that lady for malignancy. And it's definitely if the patient has a slow response to therapy, that should trigger you to go and have a look. Because it is always difficult when we see these patients. I don't like to send them for 10 different investigations. It's just not nice. The patient's trying to deal with this new diagnosis, and now at the same time you want to try and tell them you've got to go for cancer. So I think you must, don't do it on everyone, but just try and identify which one needs it.
So always, I think on our side, we always thought about the age matters. Anybody above age of 45, normal, I think malignancy we look for. And of course, we look at sometimes they should not be associated with the lymphadenopathy. So if somebody got mediastinal lymphadenopathy, then you really need to look for underlying secondary. And I think obviously, I think the age problem matters quite a lot from 45 females, males, maybe age of 50. Then you look for it. But anybody who is younger, 20, 23 is very unlikely, between that age, between 20 to 40s. So yeah. So I think we still need to do a lot of work. But I think welcome to MIDSTREAM. And I think, maybe the next topic we must just ask one of our hematologists, maybe also to just zoom in and look for us at rheumatological manifestation of the skin disease. And then perhaps, so that we could just maybe one day maybe come with a small, just atlas for South African purpose, and then just to linger autoantibody from that, And yeah, thank you.
I've got a question. So first of all, so if you suspect it and you ask for myositis profile,
Yes.
So what is the cost of it, and does it give you like a panel with all the things? With all the antibodies, and then if that is negative, do you still need to do muscle biopsy?
No.
Well, so you can talk about the cost. It is expensive. I'm not sure exactly what it costs. The issue is, let's say your patient's got a negative panel, but elevated CKs, proximal weakness. You must remember they don't do the HMG co-reductase on that panel, and so you're going to miss that one, and that's a necrotizing. So you wouldn't want to miss that. And of course, there might be other antibodies that we can't test for, because as you see, things are expanding all the time. So you can't use it as a fixed rule, but probably go and look for other things if your panel is negative. And then don't forget, obviously, other autoimmune diseases can cause myositis. So if your panel is negative, you could still have scleroderma, you could still have mixed connective tissue disease, lupus, even undifferentiated patients. So yeah, it's still possible.
So thank you so much. I think Michael can be reached through his MIDSTREAM MediClinic. What's the room number again? Sorry?
206.
206 is available. You can get an appointment as soon as possible. He's an excellent rheumatologist, and we're glad to have him in MIDSTREAM. Thank you, Michael.
Thank you.
And this coffee. Thank you.
Thank you.
Excellent.